to our discussion of the day. Nigeria battles cholera outbreak in 30 states with over 1,141 suspected cases and 65 confirmed cases reported from January 1st to June 11, 2024, resulting in over 30 deaths. WHO, UNICEF, and IOM hold emergency meeting in Lagos to address this outbreak. Lagos State Ministry of Health reports that 350 suspected cases of cholera in 29 wards across multiple local government areas, with 17 confirmed cases and 15 fatalities attributed to severe dehydration caused by delayed presentation. Medical experts warns of cholera outbreak risks in NYSC camp and schools due to poor sanitary conditions and lack of clean water and cleaning supplies. NCDC reports cholera cases in 96 local government in 30 states, with children under 5 facing substantial health risks and higher mortality rates. UNICEF officials highlight the need to prevent cholera outbreak in schools to avoid educational disruption, school closures, and reduce attendance, which hinders children's learning and development. We are now being joined via Zoom by Dr. Agbor Ebuta. I hope I got that correctly. Consultant family physician of the State House Medical Center and Vice Presidential Medical Initiative for Africa. Dr. Agbor, it's a pleasure to have you join us this morning.
It's a pleasure to be here, and thanks for having me.
Thank you, Dr. Agbor. From our introductions, you get a sense that this is clearly an emergency upon us. Give us a sense of what we are dealing with and how much that is a public health concern as it is.
Well, basically, we've had an outbreak. The epicenter is in Lagos. The numbers are out there, over 1,000 cases, and a significant percentage of them is happening in Lagos Island, precisely where you have the epicenter. In addition to that, it's suspected that you have at least 30 states involved in this current outbreak, and with a significant number of deaths. Number of death percentage is ranging around 20-15 thereabout. So we do have problems in our hands. But when you have outbreaks like this, it's important to recognize that there is some level of underreporting, mainly because there is a lag time before the data from the field gets to the central location to be properly documented. So we do have a problem, and it's significant.
All right. When we talk about Lagos and considering some of the inherent challenge with Lagos as an environment, first of all, it's access to clean and potable water is such a challenge, and you are dealing with a place with such huge population in a small density area. How long until we begin to see the contagion effects in neighboring states like Abuja, Osun, Oyo, and eventually spreading across this country if we don't do the right thing?
Lagos has probably 20 million people, give or take. It is the economic epicenter of Nigeria. There is a high influx of trading partners, people who go into Lagos and leave Lagos for economic activities. So we should expect that 1 or 2 persons would leave Lagos with cholera. And to understand the concept behind it, when you have 2-3 patients, 2 to 5 patients who have cholera and have severe disease and are ill enough to be admitted in the hospital, for every 5 patients you have that have severe cholera admitted in the hospital, you have about 95 of patients who have cholera and in the community. Out of these 95, 75 will not be aware. They would have cholera, they will not be aware, but they will be transmitting it. 20 will have cholera, but they will have mild symptoms, just a little cramps, a bit of nausea, and it's mild diarrhea, not the profuse diarrhea that we see that is life-threatening in 5%. So for every 5 people with severe cholera, you have 95 with no symptoms at all, or mild symptoms. These people are also critical because they are also a source. The fact that they have cholera and they do not have symptoms does not stop them from transmitting. They are asymptomatic carriers, and they are the ones that would transmit it. So if you have traders, businessmen, public servants who have been to Lagos and have been in contact and are asymptomatic and they belong to the 95%, they have not been admitted, they are not getting treatment, they go back to their states, you are going to expect transmission.
Right.
Now that is going to happen. So what happens if somebody is infected? How long does it take for this person for how long can this person transmit this condition or transmit cholera? For between 2 to 10 days post-infection, the person can continue to transmit. And in some cases, it has been shown that it can continue for as long as 1 to 2 weeks, even after your symptoms have resolved. So sometimes, even when we treat patients, we try to do significant sanitary controls for additional 1 to 2 weeks to prevent the small chance of transmission. So that really tells you the bulk that out of these 1,000 patients, 1,000 plus patients that we are seeing, and we suspect that they have cholera, so to speak, they just account for 5%. It means that for that number, you have at least, out of 1,000, you have at least 19,000 who have cholera but are asymptomatic. And we also need to understand that anybody who has cholera has eaten or tested fecal matter, has taken food or water or come in contact with contamination with fecal matter. And if you take a drop of fecal matter or a spoon of fecal matter, you have had exposure to fecal matter, because cholera is a fecal-oral, it is transmitted through the fecal-oral route, meaning it comes out in the feces, it contaminates whatever sources you are exposed to, and the person is infected. So to a large extent, to answer your question very directly now, 95% of patients may have mild or may not have no symptoms, and they can continue to transmit cholera within 1 to 10 days post-infection. And if they are moving from one state to the another, unbeknownst to them, unaware, they can definitely transmit if they are involved in unsanitary habits. And one of the challenges we have, some of those highly mobile people are involved in trade, small and medium scale, meaning basic trades and all of that. These are people that travel through using trailers, buses. Sometimes they don't have any special arrangements for accommodations. They sleep in the car parks, they sleep in anywhere they can get accommodation. And most of these accommodations do not have a proper feces disposal facility. So that means that this population of highly mobile people who are likely to go in and out of Lagos for trade are a significant percentage of a potential risk to our public health space. These people would be involved in open defecation and would cause a transmission of cholera to the communities that they visit outside the epicenter. But also allow me to add that the open defecation is a major factor, because if you can shut down open defecation, you are happy. But in Nigeria now, the last data we have access to suggests that we have at least 47 million Nigerians who are involved in open defecation, meaning that they just go out in any public space and they pass through because they don't have access to facility. That's about 20% of our population.
Doctor, I mean, clearly, with regards to our wash system or condition, with regard to water, access to potable drinking water and sanitary, health and things like that, the optics, the statistic is really, really bad. But in speaking to this particular outbreak that we're talking about right now, we have such a history dealing with cholera year in, year out. It is a recurring decima. What can you tell us about how we are improving the system of, tracking, tracing, and also helping create awareness so that people can do much of the heavy lifting themselves around sanitation and, some of those preventive measures that can help lessen the impact on public health. What can you tell us about how we're improving our system of early warning detection systems and everything else down the chain of management?
Okay, so a very brilliant question, and there are two components to that. Number one is you're talking about what is the system for monitoring. So there is a system that is designed using what you call disease notification officers. Now, disease notification officers are just basically designated public servants or stakeholders whose responsibility it is to monitor, document, report, and facilitate the confirmation of a disease outbreak or of a reportable disease outbreak. So in every hospital facility, you have people who are supposed to be designated. If they are not, they should be. So in a facility, you may have a facility disease notification officer. That scales up to the local government. Then at the local government level, you have a local government disease notification officer, which scales up to the state, where you have the state disease notification officer, and from the state you have a scale up to the Federal Ministry of Health, and from Federal Ministry of Health it goes up to WHO. So you can see that there is a reporting system. Now the question now is that, do all facilities, health facilities, have a disease notification officer, or somebody who is at least responsible for identifying outbreaks and channeling it to the local government disease notification officer, whose phone access, WhatsApp number, phone number, email address should be easily available and accessible? And in short periods, these people are supposed to scale it to the Ministry of Health, who will scale it for the state, who will scale it to the Federal Ministry of Health, as the case may be. So we do have a system like that in paper. The question is that this is an opportunity for us to go back and audit, is this system working? I believe that the Lagos State probably has an enhanced system because they were at the forefront of the fight for COVID and all of that, and they accumulated a lot of experience. But what's happening in 774 local governments? Do we have disease notification officers? It is very simple. The WhatsApp group now, the WhatsApp group facility allows you to add 774 people. So if you have a WhatsApp group facility and you add 774 people to that WhatsApp group, you have 774 disease notification officers from local governments in all parts of Nigeria, and they are reporting to a WhatsApp group. And you can go on to add 36 states disease notification officer, as the case may be, and you add the federal disease notification officer, all in that group. That is just a very simple and basic way to facilitate reporting, sharing of information amongst disease notification officer. Of course, there will be other channels where you have physical interactions and direct communications, but it's important that we strengthen this. On the second aspect of your question, which has to do with how have we been managing it? Yes, there's a lot of talk. There's some level of action when it comes to the management of oral diseases and the public notification and the wash intervention, hand washing and the rest. But again, we need to identify that everybody has a role. Federal government, state governments, and key stakeholders, local government, the executive arm, for example. One of the significant intervention we can put in place is make sure that every Nigerian has a toilet to defecate. It's as simple as that. I will tell you with shock, and it may surprise you, that the last time they had a local cholera case in the UK was 131 years ago. And yes, wow. over a century ago. But here we are, we still have these conditions. But if you have public toilets, and people have access to public toilets, and there is no open defecation, you will stop feces that contains cholera from contaminating water, food, or other sources. So we cannot stop people from passing stool, but we can channel this stool safely. That's why people in the Western countries, you can't be talking of cholera. You are like cholera. Oh wow! They gather and they hold a conference if they have one case of cholera because they are amazed. You understand? But we have recurrent cases. So for the key stakeholders, I do not see how a local government chairman cannot build at least one public toilet for the public use to share among political wards. Some local governments have 10 or 15 political wards. You can build public toilets that people are accessible to. You can put a small price, 10 naira, 50 naira, as the case may be, to maintain it. You do that in 774 local governments. You have sorted out partially part of this problem of open defecation. Apart from cholera, we will address other fecal-oral conditions like salmonella and typhoid and the rest. But that's one aspect. That is for stakeholders. The other thing that the stakeholders can do is that we have a very chaotic public waterworks, mainly because some states do not have a well-structured waterworks. Public waterworks will mean that you have a huge area where you collect water, you treat it, and you reticulate, you channel it through reticular pumps to homes and deliver potable and clean and safe water to homes. That's what they are doing, and that is what should be the plan. Of course, unfortunately, public works water supply has collapsed in a lot of states, and population has grown so quickly. Nigeria has one of the fastest growing populations, so our public water works has not grown at the same speed. Now, this has been replaced by personal wells and boreholes. While personal wells and boreholes provide water, they are also not exactly very safe too, because they can be exposed to undersurface contamination by feces. Because if you build a toilet that is within 30 meters to a well or a borehole, there's a chance that there can be underwater contamination. So I won't be surprised that some of the cholera cases we are seeing is because people have gone to drink water from wells that were built within 30 meters to public toilets, as the case may be, and there's been surface and underwater contamination. So at the level of the government, the executive, the local government chairman must build public toilets, monetize it through PPPs, as the case may be, and then we can cut short the public defecation. We can stop our brethren, the 47 million Nigerians who defecate openly, from continuing to do that, and then we can also, to a large extent, cut that back. The other issue of what hospitals, what can hospitals do? We have over 30,000 primary healthcare centers. It is estimated that about 8,000 to 10,000 of these primary health centers are functional. Even if these are the only primary health centers that are functional, we should have a system to massively retrain. You know, people leave, people travel, people die, people Japan, all of those things. So in primary health centers, you have a significant turnover. You know, sometimes people working in primary health centers are not well remunerated, so they have a turnover. So as they turnover, you have to train. So we have to evolve a system using technology, a simple Zoom meeting to train community health extension workers now on the current update of identification, early intervention, and health education on cholera would make a huge difference. I know that the community health extension workers have a group. They have a WhatsApp group of thousands, a Telegram group of thousands. You can train them on Zoom. You can train them. So we need to quickly, at the health center levels, public health hospital levels, we need to train people quickly, update their knowledge, early identification, management, and current updates. That's number one. We need to identify and appoint disease notification officer, so that, because what the disease notification officer does is that if there's a suspected case of cholera, the disease notification officer flags it and gets the local government disease notification officer to come and run a screening test, which will help us identify that, because there are other causes of diarrhea all over the place. So we cannot say that everybody who has diarrhea has cholera, but we can confirm bedside using a strengthened diagnostic system with a test strip. That test strip is just like the pregnancy test strip. So it is available, it's accessible, and it can be deployed. So to a large extent, we need to strengthen the disease notification system within the health space, from the primary health center to the secondary health center, to the tertiary health center, to the public health space. So we need to strengthen that.
Right. Doctor.
That's for the public, that's for the health system. Now, for the community, the community, like you pointed out, have a very important role to play. We need to do education, and that's what Trust TV is doing today, bringing key stakeholders to discuss cholera. So I do hope that a number of Nigerians are tuned into this and are listening to this so they can get involved in discussions. Right. In schools, primary schools, secondary schools, universities, they can create 1 hour to educate every member. You can imagine the number of children in schools, number of people in school. We have at least 50 million Nigerians in one form of school or another. You can imagine saying that we take out one day to do 30 minutes lecture of all the teachers. We do a TOT, train the teachers to train the teachers. At the personal level, you see, there are a lot of things we can do. Even at the personal level, we do have strategies: basic hand washing, retraining, safe water, don't eat food in the public space, wash your hands, and a lot of other things.
Doctor, pardon the interruption. Pardon the interruption. I want to draw your attention to something that is also a bit of a concern in terms of managing situations like this. For instance, a resurgence of cholera across not just Nigeria but on the continent itself is driving an urgent need for vaccine doses, as we've come to witness over the past couple of years. Since the COVID pandemic, vaccines have become quite central to help mitigate some of these pandemics or endemic situations. I mean, they have been for decades now. But we also understand that while it is a part of a solution, there is a lot of pushback on the part of the public around acceptance, for instance. So there is a well-known cholera vaccine out there. How do we fit that into the equation of a solution to what is usually killing hundreds of Nigerians year in, year out?
There are several cholera vaccines. Most of them are oral, like the Dukoral. You take it, and then it gives you protection for a couple of years, 2 to 3 years. We must understand that in vaccination, you have to get what you call a critical number. Apart from the protection, the aim of public health vaccination is to achieve, apart from personal protection of the target patient, is to achieve what you call herd immunity. So you need to immunize at least 70% of the affected population. And it's also the protection of the vaccine, of the cholera vaccine, is variable. It's variable. It can modify the disease to a large extent, reduce the severity and the duration. So indeed, the cholera vaccine has a role to play. But the thing about it is that the case of the cholera vaccine, you have to deploy it. You have to have the logistics to deploy it, and the protection is not immediate. So when you look at the whole idea around it, you find out that it may not be the major way to go. Why can we not protect our people and provide water, safe water? Why can't we educate them? Because simply boiling water protects them. And apart from that, when you boil water, you are also protected from, apart from cholera, you're also protected from typhoid infections, E. coli infections, Campylobacter infections, and other fecal-oral infections. So while vaccination is important, it is not the mainstay of this intervention. You may, however, look at certain populations that are more at risk within the structure, within your topography and geography, and say, okay, you do targeted vaccination. People who are more at risk, people at the lower socioeconomic level who do not have a steady and a safe source of water, and whose communities are contiguous, close to communities that already have an outbreak. Then you can go there and do a quick vaccination and try to mobilize them and all of that. But it is important to understand that in the center of London, in the UK, in the countries in the West that have been able to mitigate the impact of cholera and banish cholera from their public and health space for at least over 100 years, they did not use vaccination. They used strategic intervention, eliminating open defecation. Nigeria is not the most populous country. Also, why are we number one on the list of open defecation? That says a lot. And sometimes we call out the federal government, but what are the local government? I mean, governance is basically local. What are the local government chairmen doing? What are they doing? What will it take a local government chairman to facilitate? If it's a political campaign, they are going to call people and hold meetings all over the place. What is wrong with even the local government chairman getting his political aides who work per word to go around and do the needful? What is wrong with the local government chairman providing safe water? What is wrong with the local government chairman going to the primary health centers within his local government and saying, you know what, I'm going to provide emergency medications. I'm going to bring a specialist, maybe from a teaching hospital nearby, to come and do emergency training. I'm going to make sure that their IV fluids are available, their antibiotics are available. Because let me tell you something. Severe cholera is life-threatening. A patient can lose 20 liters of fluid within 24 hours. Let me tell you, you know what 20 liters of fluid is? This gallon. A gallon, the little 4-liter gallons, about 5 of them, or the 20-liter gallon. A patient can lose that. How much fluid do patients have? A 70 kg man, for example, 70 kg, most men are 70, 80. So a 80 kg man, for example, his body water content is 40 liters. So imagine losing 20 liters out of your 40 liters body water content. You are just going to go. So that is the issue. And you can lose this within 24 hours in severe cases. So you must replace it. So you need to be able to say, look, you have fluid, IV fluids, ORS, antibiotics, and support treatment. You need to have them in the communities, in the primary health care centers, because this is where most of our patients go. 70% of Nigerian patients are not insured. They pay for health service out of pocket. So at the local government level, it's still an opportunity for intervention. So I don't have anything against the vaccination. Oral vaccination. It is potent. It protects for 2 years. So every 2 years you have to vaccinate. And we are quite a number. We are 230 million Nigerians. How many people are you going to vaccinate? So you have to come up with a structure that allows you to vaccinate only those people that are highly at risk. And you know that every 2 years you have to vaccinate. But if you look at the cost and all of that, steady education, early disease surveillance, early intervention remains the way to go, and we must come up with an innovative way to provide public water supply, public works. We don't have to provide a water works that covers the whole state. You must do it, structure it in such a way that it's available and people have access to it.
Thank you very much. We have been joined by Dr. Agbor Ebuta, the consultant family physician at the State House Medical Center and Vice President Medical Initiative for Africa, who has been providing us with education, enlightenment around cholera and what we can do as a country, as a local community, as a state, as an individual, to help in the joint fight against the eradication of cholera. Like you said, it is not about vaccination, it's about putting the social amenity in place that would completely eradicate it. And then someday, probably not in our lifetime, some persons may be talking about how we have not had a single case in 100 years, hopefully. Thank you very much, Doctor, for finding time to be part of this program.
Yeah, always a pleasure. Thank you for having me.
The gratitude is ours. Thank you, and you have a great day ahead. We'll take a quick breather. When we return, it will be time for newspaper reviews. Please don't go away.